Hello. So we are very pleased to have you here on this webinar on hernia surgery. And I would like to thank ERCAT and MEDTRONIC for making this possible in advance. My name is Nicole Bouffy. Ever since my PhD at Rotterdam in the group of Professor Jekel and Lange, I'm searching for the ideal mesh. At the moment, I work as a surgeon in Maastricht University Hospital, and we do a lot of research together with Age Technical University, with the group of Klinge and Klink. Unfortunately, the ideal mesh still has to be invented. We have to overcome 4 main problems of meshes: shrinkage, chronic pain, infection, and adhesions to the mesh. And in this area of personalized medicine, there's probably not one mesh fits all. So we are very happy that we have 2 experts here today to share with us their knowledge on the search for the ideal mesh. We have Oliver Lefranc, who's a principal scientist at MEDTRONIC, and we have David Sanders, who is a surgeon at the North Devon District Hospital with special interest on hernia surgery. So we are very happy to introduce to you as the first speaker, Oliver Lefranc. He works at Trevaux Institute for MEDTRONIC since 2015, but he already did his PhD in Paris on biomaterials in 2003. And he really has a very important presentation on which mesh is the best to choose for your patients. So Oliver Lefranc, I would like to give the floor to you. Before we give the floor to you, we make you ready that you can do your question and answers in the Q&A box on the right lower quadrant of your screen, and we will answer these questions after the presentation. Thank you for being with us. Oliver.
So I share my screen. Up. So thank you, Dr. Bouvet, Dr. Sanders. Thank you for giving me the opportunity to present here. I'm indeed Olivier Lefranc. I'm part of MEDTRONIC. Obviously, this is my disclosure, but we won't speak about commercial product today. We'll just speak about what we put as science behind the hernia meshes. As Dr. Bouvet said, one cannot fit all, but we can make the choices in order to give the best chances depending on the landscape that we need. So we are here to speak about hernia meshes. Hernia meshes are implantable devices. They are medical devices, implantable, and as such, they will be implanted in a living host. When you do that, you always have a reaction, which is called the host reaction, inflammatory reaction, foreign body reaction, whatever you call it. It will always happen. A ghost material, an inert material does not exist. This is a myth. So we have to consider this inflammatory reaction, let's call it like that, and we have to know it a little bit. It's a wound healing process. We just want to keep it under control, but we need it. What we have to know from this inflammatory reaction, it's divided into 2 main phases. You can see the graph on the left-hand side of the screen. The first phase, it's called the acute phase, inflammatory phase, whatever you call it. Basically, this is the first line of defense of the body. It will try to put macrophages, defenses, and fill the wound with fibrin and collagen in order for you to walk back to safety. And then after 7 to 14 days, you've got the second phase of inflammatory reaction, which is called the remodeling phase, reconstructive phase, different word, where cells will acquire the final phenotypes. Fibroblasts will turn into myofibroblasts, and we'll have also a switch, molecular switch. And the aim of this phase is to consolidate the wound, to finalize the wound. And those 2 phases are really, really important, and I will explain why. When everything goes well here, on the right-hand side, you can see one of the Douglas curves that you all know better than me, because it's one of the standard now. it shows the healing of an abdominal wall on the top curve. And what it shows that it needs 90 days to come back to a plateau, which is only 70% of the initial strength. It means that under normal circumstances, a repaired abdominal wall is weaker than a native abdominal wall. The second thing that it shows is, if you look at the side on the bottom, the graph on the bottom, is after 7 to 21 days, you also have a molecular shift. I said the collagen 3 turned into collagen 1, so from inorganic to more organized, and which also shrink and help consolidate the wound. All those things have to be taken with care because it will drive many of the choices that we'll make when we design a mesh. So if we consider biological reaction, we know what are the main drivers of the good repair. We want a limited scarring, don't want an excessive scarring. We want comfort, nobody wants to feel the mesh, we want durability. Usually we've got a hernia and the mesh has to repair and help the abdominal wall for a long time. We will speak a little bit about integration because any medical device needs to be integrated or encapsulation usually. So we want it to be integrated, and then we'll make a focus on some of the visceral protection, IPOM meshes, for example, which compiles a little bit all those points. In order to answer to all those, in order for the white blood cells to go inside them and chase potential bacteria, it's not so simple, but I won't speak about that here. I prefer speaking about macroporosity. Those are all the space you can see in between the yarn, all the void into the mesh. It's been described as more than 1 millimeter by EHS, sometimes 1.5. I'll speak about that because I just have one more point that I want to touch here. Porosity, macroporosity, needs to remain open. And this is what some people call effective porosity. And for that, we speak about pore shape. You can imagine the mesh on the left-hand side, when you stretch it in diagonal, it will just close. While on the hexagonal pore shape, whatever the stretching direction, it will remain open. So the pore shape is also important. Now, why 1 millimeter? Consider the left-hand side, and all the round white circles represent a cross-section of the mesh which comes toward you. When you implant, you've got this fibrotic reaction, fibrosis around each yarn. If you do not have enough spaces in between the yarn, you will have a bridging of the fibrosis. Granuloma will touch each other and you will generate a plate. It would not be a problem if you did not have this second phase of inflammatory reaction. In that case, fibroblasts will turn into myofibroblasts, collagen 3 will turn into collagen 1, and other molecules like alpha SLMA will enter into the theater. And the scar will shrink. By shrinking, it will take the mesh with it. It can shrink up to 50%. The mesh itself does not shrink, but the scar around the mesh, by shrinking, takes the mesh with it. On the right-hand side, we consider that we have more than 1 millimeter. Exactly the same happens. Fibrosis around the yarn, but you don't have any bridging. And during the second phase of inflammatory reaction, everything shrinks around the yarn. You do not have the full mesh shrinking. You have 5–10% of shrinkage because you can have several layers of yarn, but you don't have the 50–60% that can be seen. Now, which is sometimes confusing if instead of speaking of porosity, we speak about weight. And the weight and the porosity are two different things. On the table that we see here, the second lightest mesh, which is circled in blue, is also the one with the lightest porosity. On this graph, on the left-hand side, we have plotted the weight, the surface density on the x-axis, and the pore size on the y-axis. 15 meshes from the market, not only ours, whatever, don't have any correlation between weight and porosity. A body does not react to weight. It reacts to surface, to geometry, to physics, but not to weight. But the weight is correlated to the strength. So it means that when you choose the weight of your mesh, you have to be careful about the strength you need, the reinforcement properties you need. And if we come back to my table, you can see here the mesh C, which was the lightest one, which is also the weakest one. So here we always have a balance in between how much force do I need versus what the body will see and how it will react. And it's a trade-off that we have to achieve. This is the main morphological, geometrical, physical parameter of the meshes. Now, the material itself also needs to be taken with care. I explain in 15 minutes something which should be a 2-year PhD, but consider that material, even for a mesh, needs to be carefully taken. It was summarized in 1985 by Professor Gristina, who explained, at the end of the day, it will be a race for the surface between cells and bacteria. And of course, you want cells to win the race. Clearly, cells have to win the race. But how can you improve that? How can you induce that a little bit more? Professor Selzer in 26 did an interesting experiment. He said, basically, cells are made of 98% of water. So the surface wettability, hydrophilicity should impact the cells. And I won't explain the graph too much, just to explain that you've got on the x-axis the wettability of the surface, which is plotted. The more you go to the right, the more hydrophobic it is. The more you go to the left, the more hydrophilic it is. You've got on blue arrow on the top left, the collagen, which is the native structure with the water contact angle of the collagen. And here you can have several polymers that could be put on this graph from the highly hydrophobic, like EPTFE, Gore-Tex. This is why when you hike, you prefer Gore-Tex thing. And you can have the two main polymers used in the mesh, polypropylene, which is a polyolefin, and the polyesters family is a PET. And both polypropylene and polyester are quite on the right side of the hydrophilicity threshold. And what it shows that the more you are hydrophilic, the better will be the cell adhesion, because they need hydrophilicity to spread and the cell proliferation. It was theory, and we wanted to check how it worked on real meshes. In biotech, in Trevoux, we've got a cell culture lab, and basically we did something really simple. We took two meshes, the same structure in order to avoid any bias. One was Parietex progrip, the other one was Parietin progrip. Sorry for the trademark, but one was made of two polyesters, polylactic acid and PET, and the other one was made of polyester, which is a PLA, and a polyolefin. And what we showed, just by using the same meshes, that after 10 days in vitro, we could see that cells have colonized the entire polyester mesh. And it first colonized the polyester compared to the polyolefin, as you can see on the right. It does not mean that it won't work, because as you can see, when they don't have enough space, they will climb onto the polyolefin, onto the polypropylene, and then they will integrate it. That's why you've got no difference. As I said, both polymers are fine for meshes. And you can see on the graph that we just have a slight delay in vitro. Now, for complete hydrophobic surface, cells do not climb onto it. And this is what we see on some barriers, for example. The green spots represent living cells which have colonized more hydrophilic parts, barrier for dual-sided meshes, while they do not climb and do not proliferate on highly hydrophobic barriers. So when we have selected the materials, when we have selected the geometry, now we can build the right mesh. And if we consider the specificity of the IPOM, we need dual-sided meshes. Why? Because when you open, you've got a hernia, you open, you place the mesh, you will have the host reaction, which will appear here. And here, the host reaction is from two origins. The first one is from biological reaction between viscera and mesh. And the second one is physical. You've got some friction of the viscera onto the mesh. So you've got wounded surface, fibrin, which is secreted, and during the second phase of inflammatory reaction, we'll have fibrous adhesion. So what can we do against that? It could be a chemical treatment, but you would impair the inflammatory reaction. So since the year 2000, the dual-sided meshes appear in order to put a barrier in between the viscera and the mesh. And those are the kind of meshes that you can find on the market. You've got a barrier on one side, the mesh on the other side for the integration onto the abdominal wall. Barrier can be permanent, can be resorbable. They all work the same. So how does it work? It's something really important to understand, because we want the mesh to be colonized by mesothelial cells in order to build a new peritoneum. And at the same time, it has to be simultaneous. We want the mesh to be incorporated into the abdominal wall. So on one side, the muscle will go to the mesh, anchor it onto the abdominal wall, and on the other side, mesothelial will climb onto the barrier and take the place of the barrier to have a neoperitoneum. And this is what we show here. The inflammatory reaction is centered onto the yarn, nice tissue in between neoperitoneum. On this example, it was a mesh with 2 barriers on each side, and it was important because in that case, the mesh could not be anchored onto the abdominal wall. It could not be integrated by cells. So after the fixation result, the mesh was not stuck and could move onto the abdominal wall. It was not simultaneous, so the body raised an alarm, inflammatory reaction went wild, and you had an encapsulation of the mesh. As I said, it has to be smooth and simultaneous. So this is one study. This is where you will see trademark because it's not hard studies which compare and say there are 3 families of meshes for IPOM. On the y-axis, you've got the percentage of visceral attachment, and it shows that if you do not protect the mesh, it will attach. So if you have some synthetic old-fashioned meshes in between, which are better results, but not as good as native tissues, now, to be perfectly honest, they should decrease the new technologies which are on the market today. But in any case, the closer you are to native structure, the better will be the adhesion. So I've tried to summarize in 15 minutes many things, but if you have to remember 3 things from this presentation, is first, porosity is the key. The weight itself needs to be taken into account, but it's not the key. Second, a barrier. We want to prevent visceral attachment, but you want to promote cellular attachment. Cells need to colonize even a barrier. And then it's a trade-off in between the host reaction, the performance you seek, but also the user and the procedure. Depending on what you will do, you will choose to pick up a different mesh. And maybe in the next future with the new robotics and things like that, this will change a little bit and will shift towards the right on my scheme. But all those host reaction, mesh performance will always remain true. So thank you. I will give back the mic to Dr. Bouvy for the next part. Thank you for your attention.
Thank you so much, Olivier. We really enjoyed your talk, and there are some questions. So of course, the audience is very curious. Which mesh should be used? One of the questions is, which mesh do you think is better, to use a mesh made out of polyester or made out of polypropylene, both monofilament meshes?
It's a discussion that I had during the last EHS. I would choose, and I have chosen for my father, to be honest, polyester mesh. Because imagine if you consider the case, someone comes toward you and say, okay, I've got 2 materials which will give probably the same clinical results at the end. But when I do my first test in vitro, one is better than the other one. You would probably pick up the one which in vitro has better results, even if we tell you that at the end it will be the same. So I would go for something that my body prefers, my cells prefer, even if I cannot see the clinical difference. Just for the first step, I do not want to go against my body. Now, as I said, I could have a polypropylene mesh because they are on the right side. It's not that it's bad meshes. I prefer optimized against good.
Okay. And the question is, of course, more and more hernia surgeons try to avoid the contact with the abdominal cavity, with the bowels and the meshes. So if the mesh is in the abdominal cavity, which do you think is the best barrier that should cover the mesh to avoid adhesions?
It's nearly the same answer as before. For me, the best barrier is something which is really close to the native structure. And collagen is an extracellular matrix that the body will secrete. So that's why I would go to, first of all, I would go to an hydrogel, not to a permanent barrier, because it has to disappear to come back to the porosity and integrate the mesh. And between all the hydrogel, I would go to the more natural biological one. That's why I would prefer collagen. As I said in the graph before, the new synthetic materials work fine, really fine. And I could have one, but once again, if I have the choice, I would prefer a collagen or a native structure equivalent one.
Okay, then another question is, we have heavy and lightweight meshes and micropore and macropore meshes. And do you think there is still a place for certain patients to use heavyweight meshes with small pores?
Well, I think that a lot of evidences have shown that small porosity was not the best. So I would not see why now any surgeon would propose a small pore heavyweight mesh unless you've got a huge abdominal wall defect that you need a lot of strength. But except from that, I think there are enough evidence now to show that porosity is really important, and the weight itself is just for the performance, mechanical performance of the mesh. So it does really depend on the patient disease, I would say, but for regular hernia, I don't see why it would go and take the risk to jeopardize the outcome by something which is well described in literature now.
Okay, and I think the last question, if you want to fixate a mesh, do you have tips how to fixate it with what kind of sutures?
So usually, you mean sutures or tacks? Because there are several studies which show that, for example, it has been believed that double crown was more performant than single crown. And when you look at biomechanical publication, it shows that single crown may work better than double crown, actually. So I would put not too much tack. Putting 30 tacks on a 12 centimeter mesh would make no sense. So, but I would try to go on the literature and see, depending on the defect, depending on the size of the mesh. If I have to go, I would go to the main crown of the mesh, not to a double tack. I would close the defect in iPod, for example, to avoid having these big holes which could place the mesh with it. Now, regarding sutures, I like what we call the barbed sutures, because you go in one direction all along the mesh and it sticks into the tissue without making big knots. And we know that the knots on the mesh could attract some adverse event, for example. So I like the barbed sutures moving all around the mesh, and I think it's a safe way to fixate the mesh, to affix the mesh to abdominal wall.
Okay, thank you. Then for the moment, probably we know not enough about all the experimental work that has been done on the search for the ideal mesh. And now I am very happy to introduce to you Dr. Sanders, who is a surgeon at North Devon District Hospital, which is a center of excellence in hernia surgery. And we are very pleased to have you here, because we really want to hear from you which mesh we can use, especially in infected, contaminated area. And before we are going to have your talk, we would like to ask the audience some questions about which mesh they would use in certain circumstances. And David, is your question within your presentation, or can we have the questions from ERCAT?
If we can have the question from ERCAT, that'd be perfect, because I don't have it within my presentation.
Great, there's the first question. So during an open incisional hernia repair in a clean contaminated field, which mesh would you use? And then it's important, of course, if you have a clean contaminated field, then we mean field, for example, where a stoma has been, or which has had a violation of the gastrointestinal tract, for example, repair of an incisional hernia during a sigmoid resection. What kind of mesh would you use? And is the audience able to vote? Okay, and can we have the answers of the audience? Or do we need more time? Okay, so most people would use a large pore synthetic mesh. In this case, some biological meshes, biosynthetics, and there are also people who would not like to use a mesh at all. So we will ask these questions at the end of the presentation of David again, and we will see if there are some changes. So we have one other question. Can we project that question? Okay, so the question is, during an open incisional hernia repair in a contaminated field, what mesh would you use? And then it's important to know that a contaminated field is, for example, surgery for a replacement of an infected mesh, or in a septic patient with wound dehiscence. So more severe infection than the patient that was in the last question. So did everybody answer this question? Can we please have the answers then? So what we see is that most of you would not use a mesh at all. Hardly anybody would use a synthetic mesh. And if you choose for a mesh, then it would be a biological mesh. So that's very interesting. David, please tell us your experience and share with us what you know about the use of mesh, mainly in contaminated patients.
Well, thank you very much. And thank you very much for ERCAD and MEDTRONIC for putting this talk on. And it's great to come to you across the power of the internet. It was interesting to see those answers, and I'm certainly not going to tell you which mesh to use. What I'm going to do is talk about the parameters that are important, or that we think we should know about as surgeons, which will influence our decision on the choice of mesh that we use. And we all like evidence-based medicine. Every company will tell you that their mesh is best. So where the evidence exists, I'll try and run through the evidence, and especially in those areas which might be a little bit contentious or throw up some surprises, which is why I asked the questions about contaminated fields. So before I begin, as long as this moves along, these are my disclosures. And whenever I give a talk on mesh, I always think my disclosure list is probably going to be a little bit smaller at the end of the talk. So to mesh or not to mesh, well, really, that's certainly for incisional hernias and for most ventral hernias. That's not really the question anymore. This is one of many systematic reviews out there looking at the use of mesh versus sutures. And if you look at the forest plot on the right, you'll see that there's improved outcomes with the use of mesh in almost all of the studies. The reason I said incisional hernias, I think there's probably a role for suture repair in the right patient by the right surgeon for inguinal hernias, and something that should be offered to our patients. But for most surgeons, they'll still be using a mesh. But in saying that, mesh is only one component. And the questions that came after the excellent first presentation about whether polyester or polypropylene should be used, it's such a small component of the repair. And arguably mesh, and the reason it's in small font there, is a very minor factor compared to some of these other components. Patients, their risk factors, making sure that they're pre-optimized, this really horrible topic of the surgeon as a prognostic factor, and the surgical technique, and then comes the mesh and the fixation technique and their post-operative care and rehabilitation. So it is only one small component that influences outcome. These are some of the properties of the ideal mesh. I think, as we've already alluded to, this doesn't exist. So I think when we're looking at mesh, we have to try and identify what the purpose of mesh is. In 1959, when Usher started using the first meshes, they knew a little bit about tissue ingrowth, but really the mesh was there to act as a dam, as a strengthening reinforcement material. We now know, and what we've heard about in the first presentation, really that's not how mesh works. It acts as a scaffold and encourages tissue to grow into it. And it becomes a balancing act, a balance of getting enough of foreign body reaction to encourage mesh ingrowth to stop recurrence, but at the same time not affecting in a negative way the compliance of the abdominal wall, things that can affect functional recovery, cause chronic pain, cause infection to occur. All meshes shrink a little bit, but hopefully they don't shrink too much. And again, that's going to move back to the recurrence side. And then there's this other metric, which I'll talk a little bit more about later, which is cost, and also to some extent handling. This is a list that I made back in 2010. It goes on and on. So I've just put some of the bits down of various meshes. Basically, the point is showing you that in 2010, there were more than 260 meshes in the market. Whenever there's 260 of something, it means none of them are perfect. If there was a perfect one, there'd only be a few. So how do they vary? Well, we've already heard a little bit about the polymer or polymer blend, the filaments, the pore size, the coatings and the additives, and again, some more microscopic images of different woven meshes. They vary in their mechanical properties as well, their tensile strength, bursting force, elasticity and stability. And these again showing a few different ways that the meshes are tested in a laboratory. And then there's this one very interesting concept about anistropy to do with meshes, and certain meshes have an orientation. So they will be very strong in one direction and very stretchy in another direction, which means that they have an orientation. Some meshes display a lot of anistropy and other meshes don't. So a lot of surgeons don't know whether their mesh that they're putting in does have anistropy or not. And if it does, it has to be orientated correctly before it is placed into the patient. This is a classification from Klinger, which is probably the most widely used classification, classifying into class 1 large pore meshes or class 2 small pore meshes. And these meshes again can be subdivided into monofilament, multifilament or mixed structure or polymer or polymers. Class 3, which are meshes with special features, and actually what we mean really by these meshes are the coated meshes. Class 4 meshes with films. That sounds like coated meshes, but it's not coated meshes. This is really EPTFE type meshes which form film-like structures rather than having special coatings on them. Class 5, which are the 3D meshes, which include plugs and types of 3D meshes that may be used for laparoscopic inguinal hernia repair or robotic inguinal hernia repair. And class 6, the biological meshes. The reason I've gone through those classes is we have to look at what the mesh is trying to achieve. And this is just a random selection of meshes. That red line is the normal bursting force of the abdominal wall. That top red line is, in someone's got a weak abdominal wall, that's really going to be the top limit of bursting force. If we look at the small pore meshes, and these meshes over this side, the strength of the mesh once it's incorporated is way over that limit. So this is massive overkill here. For most large pore meshes, they're over the limit. When we started to, we don't really talk about lightweight or heavyweight, we talk about small pore or large pore, but there were some meshes that were developed that were the so-called ultra lightweight meshes. And actually they did fall below this threshold. So certainly you don't really want to be using a mesh. I don't know if you can see the arrow, my arrow on my screen, but if you can, you don't really want to be using a mesh that falls below these thresholds. And these are the sorts of normal pressures exerted on the abdominal wall. So certainly small pore meshes, someone asked about small pore versus large pore. It's massive overkill. But why do some people prefer them? Well, perhaps they're slightly easier to handle. They're less floppy. And if it handles better, especially in a laparoscopic or robotic setting, it may be that it's easier to deploy, it gets deployed better, and therefore the risk of recurrence goes down. One of the questions, I'm really glad someone asked this, was about anti-adhesive barriers on meshes. These are some of the studies. This was up to about 2010 again. It goes on. This list goes on and on of various meshes being used with adhesive barriers. What's really interesting is, as you look through the list, and these are all animal models, all these studies were done in animals. They weren't human trials. The mesh that causes fewer adhesions and the mesh that causes more adhesions just keeps flipping over depending on who's done the trial. There is no consistency at all. And in fact, for anyone who does lots of work on recurrent hernias, where people have had intraperitoneal meshes, even the best barrier coated meshes, you do tend to get some adhesions. And certainly if you don't get adhesions to the mesh, you tend to get adhesions to the fixation device. I talked about this metric, this cost metric. I think, you know, when I started surgery, I wanted to be a good surgeon. I wanted to make sure that I knew how to do the operation. Then came choosing the right patients to operate on. And then all of a sudden, this new thing was introduced, which was cost. And this is a graph of spending just in the National Health Service in the UK, but this is reflected across the world. And the cost of healthcare delivery has gone up and up and up. And it's something as surgeons that we're responsible for making sure that, that we're aware of. And really what we don't need to be aware of cost per se, but we need to be aware of value. And value can simply be defined as quality divided by cost. If I explain that a little bit more, by quality, we may mean metrics such as recurrence, chronic pain, wound complications, making sure our patients have good quality of life afterwards. Cost, we may be talking about hospital visits or length of stay or readmissions, which is a big star, because if you have complications and readmissions, that's very costly, but also resources. And if you can make the quality of the surgery go up, but the cost stays the same, the value goes up. If you make the quality stay the same and the cost goes down, the value can also go up. What you don't want is the quality to go down, but the cost to go down even more. That would be an artificial inflation of value. And it's our responsibility to make sure that we add value every time we introduce something. All patients are different as well. So this is the ventral, again, going back to ventral hernias, this is the ventral hernia working group classification. We have patients that are at low risk of complications, have no history of infection. We have those that have some comorbidity and a little bit more complicated. We have those that have potentially contaminated fields, getting more and more complex. And then we get to the grade 4, those infected meshes, the disasters, the septic dehiscences. I think we can split down the middle there, and keeping it very, very simple, in my opinion, and this is only my opinion, actually all of these before that line can be fixed with a large pore monofilament mesh in the interest of keeping costs down. Perhaps for the grade 4 infected ones is more of a debate, and that's what I'm going to spend the rest of the talk talking about. Do you use a biological mesh? Do you use a biosynthetic mesh, or don't you use a mesh at all? And then of course there's the meshes that go inside the abdominal cavity, so the meshes with actually it should say class 3, as I pointed out, class 3 meshes that have a film. I very much feel, and there's an exception to every rule, but I think as a general rule of thumb, and sorry because Dr. LeFranc spent a long time talking about intraperitoneal meshes, I don't believe meshes belong in the peritoneal cavity if you can keep them out. There are exceptions to every rule, and there will be cases where it's very appropriate. And I know that IPOM, laparoscopic IPOMs, are a very well recognized technique. I think in years to come, we'll look back on it with some regret. So moving on, so I want to talk about newer meshes. So not talking about the standard meshes that we use. What do they try and achieve? Well, some of them try and make it easy. So they might have filaments woven into them to make them easier to handle. Some of them are for these infected fields, and that's really what I'm going to talk about, or what are perceived to be more difficult fields to work in. And some of them have very clever things like nanotechnology or stem cells, but most of those are just in experimental phase. I'm not going to talk too much about that at the moment. So what is the evidence? This is a great paper written by this group, systematic review of the evidence of the use of biological or biosynthetic meshes in abdominal wall reconstruction. I'm just going to start with the biological meshes. They looked at 32 studies. The average number of patients in these studies was only 41 patients. So really small study that you would argue are very much underpowered. In clean contaminated cases, the risk of the rate of surgical site infection for biological mesh was 31.6% versus 6.4% in synthetic mesh. So in this meta-analysis of systematic reviews, the pooled rates of infection with biological mesh was much higher than it was with synthetic mesh. In contaminated cases, the rates were similar, but the pooled recurrences with biological mesh were 27.2% versus 3.2% for synthetic mesh. So the authors of this, and some of the authors are quite strong advocates of biological mesh, concluded that there isn't the evidence to support its use. And in fact, in the US, no biological mesh has FDA approval for use in a contaminated field, despite the fact that we use it lots in contaminated fields. What about biosynthetic meshes? Well, there's 3 on the market. I think I'm allowed to name them because it's pretty obvious what they are. The top one is Tiger Matrix, which is made of two different polymers. One which loses its strength at 14 days and fully resorbs at 4 months. The other which loses strength at 9 months and fully resorbs by 36 months. The next one's made by Gore, which is BioA. It loses its tensile strength at 3 months and is fully reabsorbed by 6 months. And the last one is Phasix, which is made from a component of E. coli K12 bacteria through special fermentation techniques. It loses its strength at 4 months and is fully resorbed at 18 months. Just remember that 18 months because it becomes important in one of the later trials that comes back. One of the more interesting things about that mesh in the laboratory is it maintains wound pH. So if you compare it to something like Vicryl mesh, which was often used when people were in tricky situations in the past, Vicryl causes quite a rapid drop in pH, which can blunt the inflammatory response and may have influence on the way that the body responds to infection. So a lot of people use these meshes, as I'll go on to show you what's the evidence for their use. And we'll start in the laboratory. So Tiger Matrix, a sheet model was used. Histology was performed at various intervals on a small onlay patch that was put onto the sheep and harvested, and they compared polypropylene to Tiger Matrix. Tiger Matrix had a slightly less inflammatory response and looked more like native abdominal wall, which sounds very positive. Total collagen deposition as well as mature collagen. So this is the type 1:3 ratio. So what we're trying to do is achieve good architectural collagen rather than just a scar, was higher in the Tiger Matrix. So again, that's positive things, but it is a sheet model. It was the only animal study for Tiger Matrix. Gore BioA, there were 4 animal studies. The first looked at BioA versus 3 commonly used biologics. BioA again had increased cellular and vascular ingrowth and graded collagen deposition, and the collagen was of the good type of collagen. The second study looked at BioA versus Tiger Matrix versus Vicryl, and this time it was looking at infection and the ability to clear MRSA. It was a rat model, and BioA was the best at clearing the 10 to the 6 concentration. There was no difference at the 10 to the 4 concentration. The third study looked at BioA versus Phasix, a rabbit model, this time inoculated with a higher dose of MRSA, and this time Phasix cleared the inoculum much better. 78% of the inoculum was cleared with BioA only 20%. And then in the same study, they tested for strength at day 7, and Phasix had only a 13% reduction in strength and BioA a 91% reduction in strength. The last study is BioA versus Phasix again. And this was a rat model harvested at 24 weeks. and BioA had a greater initial inflammatory response in the first 4 weeks, but after that, the inflammatory response looked very similar. So those were all the animal models that were done. This is the Phasix study. Phasix also looked at Phasix a sheet versus a Phasix essentially plug, which were harvested at 52 weeks, and the burst strength was greater than that of the normal abdominal wall. So it's creating a very strong scar plate in an animal study. But that's all well and good. Those are just animal studies, right? So we want to know what happens in real life. Tiger matrix, an inguinal hernia study, which is an interesting type of study to do. Only 40 patients included. You'll see why only 40 patients. At 3 years, 20% had a recurrence, 16% had chronic pain, and 10% had mesh sensation. So not sensational results. A study looking now at reinforcing laparotomy wounds with a tiger mesh onlay. This time only 16 patients, but they did have 3 to 4 risk factors for dehiscence. At 9 months, there were no dehiscences and 2 SSIs. That is it. That is all the clinical trials that were done for tiger matrix. BioA, a much better study, 104 patients. This time they truly were more complex hernias. They were contaminated hernias, greater than 9 centimeters, with BioA used to reinforce the fascial closure. But there was a lot of heterogeneity in the way that the mesh was put in. 90% were retromuscular, 10% intraperitoneal, and a large proportion of patients required either an anterior component separation or a transversus abdominis release. And at 24 months, there was 84% follow-up and a 17% recurrence, which sounds bad, but actually this is a complicated group of patients, and I think 17% recurrence would be very acceptable. The difficulty is it's very hard to know what to make from a group of only 104 patients that have had such a variety of different procedures done. What about Phasix? Phasix, a study with 120 patients, this time clean wounds, greater than 10 centimeter defect with less than 3 previous repairs, but at least 1 high risk comorbidity. Again, a lot of heterogeneity in the way that in the position that the mesh was put in and whether a component separation was performed. 18 months, 79% follow-up and 9% recurrence. So from the conclusion from this study was that actually Phasix was a very good product. But I just highlight here, this is done at 18 months. 18 months is just about the time when Phasix is being resorbed. So it hasn't quite gone yet. So really, I would argue that that's too short a follow-up period to be able to draw any strong conclusions. The American Hernia Society Quality Collaborative decided to have a look and see what the adoption was like in the US of biosynthetic meshes. 8.5% of repairs that they looked at over the time period, so 175 cases, had used biosynthetic meshes. And in 57% of those cases, they were clean wounds. When they looked at those patients, there was a 2 times higher risk of superficial surgical site infections and a 5 times higher risk of deep surgical site infections, or organ space infections. When they were propensity matched to make them higher risk patients, CDC 3 and 4, and they compared the use of polypropylene versus biosynthetics, the surgical site infection rate with polypropylene was 11% compared to 22% with biosynthetics, with a requirement for intervention of 13% of those with polypropylene, but 24% with the biosynthetics. Amazing, amazing. So this is Todd Henneford's slide, and I thank him very much for this. This is Phasix sales over the year between 2014 and 2017. By 2017, Phasix had sold over $166 million worth of Phasix in the US. It had been put in over 36,000 patients. That was the same date that the first clinical article was published. So without any data, 36,000 patients had the implant put in. You know, you don't need to go far to see these sorts of things. We all know about it now as surgeons. Patients are very aware. There's been a lot of problems with vaginal mesh implants. There's a lot of misconception about mesh. you know, I can't go and throw anything in the rubbish bin, in the garbage bin in my house without my wife telling me to make sure that I recycle everything. We have people like David Attenborough, and wherever you look, telling us that plastic is the worst thing in the world. So when we tell patients that we're going to be putting plastic or synthetic meshes in, it's not surprising that sometimes they have a look of horror. And it's our responsibility as surgeons to understand the evidence behind their use and to be able to reassure our patients that they're safe, and also to know why they're safe. And therefore, it is really important that we do know what we're implanting, and also we know the evidence behind its use. Thank you. I'll stop there.
Thank you so much, David. It was an excellent overview of what is known. And it would, of course, be interesting to ask the audience the same questions again. But due to time, and because we really love to also have some time for questions and answers, I would only love to ask the first question again. So if there's a change in people who go from synthetic, yes. So during an open incisional hernia repair in a clean contaminated field, so stoma, reversal, or sigmoid resection in combination with the hernia repair, what kind of mesh would you use? So can we already have the answers? So I really think, David, you did a good job. There has been a shift to a large pore synthetic meshes. And what you showed is that we have less recurrence and less infection. So we really should use this large pore size synthetic meshes, and it's cheaper. Okay, from the Q&A box, please, I'd like to encourage you to put your question in that box. We have a question from Fadi Al-Hussein, and he asked if in case of a strangulation of a hernia, what kind of mesh would you prefer?
I'm presuming you're talking about an inguinal hernia. I'll answer that first of all for an inguinal hernia. I think whenever someone's presenting as emergency, the game changes. You know, when we repair hernias electively, we're repairing it as a quality of life procedure. It's not to save someone's life, it's to improve their quality of life. When someone comes in as an emergency and they've got, whether it be an incisional or an inguinal hernia, and they've got ischemic or dead bowel within the hernia, the game's changed. And actually now you're not trying to fix the hernia, you're trying to save their life. So if it was an inguinal hernia and it was strangulated, and actually you went to do the repair and there was a little bit of bowel sitting in there and it looked a bit of angry and there was a bit of fluid, but the bowel was still viable, I think you can get away with a large pore synthetic mesh in that setting. And the same for an incisional hernia. However, if the bowel's perforated or dead, or you're really worried about a mesh infection, you can always perform a simple repair, and they can come back and have their hernia repaired another day, because what you're really trying to do in that instance is to save the patient's life. But for most of those cases, a large pore synthetic mesh, in my opinion, is absolutely fine.
Okay, and if you use a mesh, do you use antibiotics to protect your mesh?
Yes, so I mean, I think the guidance for antibiotics is, there's been lots and lots of reviews that have had that looked at the use of antibiotics. So if we go again talking about inguinal hernias, well, I wouldn't routinely use antibiotics, but in a patient that's high risk and certainly having a strangulated hernia, that would fall into the high risk category. We give antibiotics, absolutely, okay. And that's what the evidence says.
And for how many days?
So I'd give it at induction, and then probably complete a course. But that's a little bit questionable whether you complete a full course or you just give them a single dose of antibiotics when the mesh goes in. Okay.
Then we have a question from George Arturo. If you have a colon strangulation and an incisional hernia, what kind of mesh would you use? I think you already asked that.
You said restitution. I wonder, does that mean a colonic resection or closing a stoma? Or, I mean, I think as long as the case it falls in the clean contaminated category, so actually there hasn't been gross contamination, it's fine to use a large pore synthetic mesh.
Yeah, okay. Then, do you understand the question of Mircea?
In a case of an Amiens hernia after appendectomy, so an Amiens hernia, and then you're doing an appendectomy on it because there's an appendix sitting in the hernia, what kind of mesh would you use, if any? Again, if it was a slightly inflamed appendix and actually the surgical field looks pretty clean afterwards, I think you can use a large pore synthetic. Certainly if the appendix was perforated or there was pus in the abdomen, I wouldn't put any mesh in. I don't think you need to. You can always come back another day and fix the hernia. Sort out the appendicitis first of all.
Okay. Then we have Alexander Xamzim. If you have stool spillage during an elective case, what do you do? Do you place a mesh or not?
Stool spillage from the patient, yeah.
Yeah.
Then you, yeah, I mean, it depends how much contamination. So I think if you have a little bit that you can clean up very quickly, I think you can wash the abdomen out, keep it nice and clean still, and a little bit of stool. I don't think it's going to cause a big problem, and you can go ahead and use a mesh. If there's gross contamination, if you totally lose control, then you know, you have options. You can either not use a mesh. You can use a biosynthetic or biological mesh, of course, but you have to know the limitations and why you're using them. And you have to. So if you think it's the be all and end all, then I think certainly from the literature, the evidence doesn't support that. But if you use a synthetic absorbable mesh, at least the mesh goes if it got infected.
Yeah. Okay. Yeah. Then we have Dr. Mohammad Hussain, and he asked, have you ever seen allergic reactions to meshes, and what do you do then?
Well, you hear a lot about it, don't you? About patients, especially from patient groups, saying that they have an allergy to the mesh. Is it a true allergy? I'm not sure, because then they'd be allergic to polypropylene sutures as well. So, you know, I always explain to patients that the mesh is the same material as sutures. Sutures are also plastic. So I think a true allergy to polyester or polypropylene is very, very unlikely, but I'm sure that there is the odd case out there. Sorry, I've lost the questions, just disappeared off the screen. What was the second
the allergic reaction to meshes? Do you see that?
So I don't think, I mean, I think it's something that you need to be able to address with patients, but I don't see it as a real problem. I think occasionally we see patients that come through that have had a lot of mesh repairs before, and they've had a lot of problems with the mesh. And I think in those patients, you probably before you reoperate, they should have formal allergy testing done. But I have never seen a true case of that's never come back positive, showing that there is a true allergy to polypropylene.
Okay, thank you. So I think we have one last question, and what we can do is we can go on asking these questions, and they will be answered on the Facebook channel of Brian Davids, and you will hear from that afterwards. So I think the very last question from Lindsay Vejarano is a very important question, and that's about how to prevent hernia formation. What about prophylactic meshes? How do you close your abdominal wall? Do you use a 4:1 ratio? And which suture material do you use?
Okay, so I mean, I think there's a lot of evidence supporting small bite closure. So that's what Nicole was just mentioning. That you see that especially for laparotomy closure, that the linea alba is very much like a tendon, and you're using a nice small bite closure. I think the question is actually about prophylactic mesh on top of that. There's been some very good results with large pore synthetic meshes for that use. But there's also, so if you were going to use anything else, it should really be done, I believe, in a trial setting, because the evidence isn't there to support it. But certainly there would be an argument in that sort of case for a biosynthetic mesh, something that didn't last permanently, but that should really be done, in my opinion, in a trial setting.
So David, do you think there's already enough evidence to use a prophylactic mesh when you do a repair of a stoma hernia, or if you create a stoma, to use a preventive mesh?
Well, there are lots of people who would say yes. It's actually not an operation I do, so I'm probably not best placed to comment. If you ask someone like Philippe Moussoms, he'd say yes, there is a lot of evidence to support it. So yeah. I think you need to look at where the evidence is. I'm probably not in the best position to be able to answer that question, though.
Well, I agree. There is enough evidence to put preventive mesh in stoma creation, and also, of course, after aneurysm repair, open aneurysm repair, you should use a prophylactic mesh in those cases. Okay, it's 8 o'clock, and I think we have to close this excellent session. And we can go on, and we will give you the link to the Facebook channel. And this all will be also, you can see this webinar on the ERCAT site. And you'll probably get an email about how to go on with your questions on the Facebook channel.
I took a photo of the questions that you've asked that I haven't had a chance to answer. I'm very happy to answer them tomorrow. They're really good questions.
Yeah.
And just because I say something doesn't mean it's right. It's just my view. So.
And that's the great of the panel. Then we can have a lot of experts answering your questions. So I would very much like to thank ERCAT and MEDTRONIC, and of course the excellent speakers of today, Olivier Lefranc from Trevoux, and Dr. Sanders, who is also a very expert in this field and wrote a lot of guidelines and more than 50 publications on hernia repair. Thank you so much. Bye-bye.
Thank you. Bye-bye.
Are we all fair?
Kat, are we all fair?